AI in.
No, we're all done with AI.
No, it's AI in elections.
It is shit.
Hi, welcome back. We are gonna have legislative council walk us through an amendment that we are proposing to H5. What is the?
588.
588, which is a bill that was voted out of government operations, I think whenever last. And just FYI, the legislative council who drafted this was unable to be with us, so Jen's gonna, Jen's pitching in for it.
All right, so hello again, Jen Carby from the Office of Legislative Counsel. Here is the language, as the chair said, this is an amendment to H 588, which is the OPR, miscellaneous OPR bill. And this would add a new section around pharmacists to specifically address, in the scope of clinical pharmacy, pharmacists not just prescribing, but also doing some testing. So under existing law, a pharmacist can engage in the practice of clinical pharmacy, including certain prescribing, but there are certain things they cannot do. And one of those under existing law is they cannot initiate antibiotic therapy except pursuant to a collaborative practice agreement, which is an agreement with a particular prescriber, or a state protocol. If the Commissioner of Health adopts a protocol saying that there are certain things a pharmacist can do, and in this case, can initiate antibiotic therapy. So again, under existing law, the only exception around initiating antibiotic therapy is pursuant to collaborative practice agreement. And then this would add or state protocol. Also under existing law, it specifies the context in which pharmacists can prescribe. And under that, we have this state protocol. Because I don't think we've looked at this language together, under existing law, a pharmacist can prescribe, order, or administer in a manner consistent with valid state protocols approved by the Commissioner of Health after consultation with the Director of OPR and the Board of Pharmacy and the ability for public comment. The pharmacist may prescribe, order, or administer. And under the list, under existing law, and this isn't changing that one, emergency prescribing of albuterol or glucagon while contemporaneously contacting emergency services. There's some life-saving stuff. This would strike out language authorizing the, keep forgetting to lead in, prescribe, order, or administer tests for COVID-19 for individuals by entities holding a particular certificate of waiver. This is some of the COVID era specific language, and you've got a broader version that's coming up as the new law. And also striking out the specific language around tests for SARS-CoV. Anyone remembers that was what we were calling it at one point? Again, tied to this certificate of waiver under federal law. And instead, this would add, after the existing provision for emergency contraception, this would add tests waived under particular provision of federal law for COVID-19, influenza, and streptococcal pharyngitis and subsequent drug treatment. I think you will hear from OPR why they are asking for that link.
Any questions? Great. Great. Oh, wait, so close.
Yeah. I just didn't know what 42 USC, is that relevant?
I believe it is. I think there are certain tests that are waived under federal law that OPR is about to tell you about.
Okay, great.
I'm looking
Thank
at
you.
Jen and Carrie, and if they are not, then I will look into it and tell you more.
Thank you.
Thank you.
You guys did 42.
And
CFR, I wanted
Yes.
when I had that point, I've never seen that.
Yes.
so there's a change to it?
Yes, there is a minor change. The reference should be to the code of federal code of federal regulations, not the United States code.
Okay. Jen, did you want to come on? Oh, different Jen.
Yes.
Jenny, I shouldn't. Jenny. Hi.
Jennifer Colin, Director of the Office of Professional Regulation. Thank you for having us today. OPR does support this amendment to H 588. It allows test to treat for very limited conditions. And the way this amendment came about, our understanding is that as part of the Rural Health Transformation Program, there have been funds approved for the fiscal year, and Test to Treat was one of the initiatives that was intended to be covered by that Rural Health Transformation Program. So these statutory revisions include that pursuant to state protocols, which the Vermont Department of Health, the Commissioner of Health would approve, and work with OPR and the Board of Pharmacy and stakeholders to come up with those protocols, but that those protocols could be used for point of care testing and treating of COVID-19, influenza, and strep. And again, those are obviously very limited conditions where the testing and treatment is fairly straightforward. And there are a lot of other states that actually do this test to treat or that allow this test to treat at point of care in pharmacies. And I think part of the reason is because it's an access issue. You know, it's easy for folks to walk into their local pharmacy and receive these kind of services and get tested and treated for very quickly, rather than having to make appointments with their primary care providers. So it's a way to increase access, and again, done in a number of states. And from OPR's lens, our lens is always what is safe for the public. Public protection is our mandate, and this is well within the pharmacy scope of practice, and we support the language.
So currently pharmacies can test,
For COVID.
but they can't actually do anything. If somebody was to test positive, they would have to then send that person to a prescribing physician to prescribe the treatment or the medication that.
Or if they have a collaborative practice agreement with a provider, I think they would be able to prescribe treatment. But unless there's a state protocol or an order from a provider or a collaborative practice agreement, then pharmacists aren't able to prescribe.
This would allow that within their scope of practice.
Correct.
Right? Go ahead.
Does that mean that each pharmacist then has to update their scope of practice, or is it a blanket? How does that work?
No, a scope of practice is essentially dictated by, first of all, pharmacy education, which is extensive in this area. So I think it's well within, and I'm looking at our EO for the Board of Pharmacy, but it's well within the training and education for pharmacists in general. And then, you know, additional training and experience that any individual pharmacist might have can also dictate a scope of practice. So it just depends on the individual's training, experience, and education.
Any other questions for Jen? All right. Well, thank you.
Okay, great. Thank you.
Lauren is not coming. Correct.
She's in another committee
Oh.
and sends her apologies.
Okay.
Sorry.
Probably down in GovOps. We miss her.
will.
GovOps gets all the love from Lauren,
Yeah.
it seems like. Dr. Hildebrand.
Yeah.
Good afternoon. Thanks for coming in on short notice.
Good to be here.
You had a chance to look at the language of this,
I have.
and did you want to address it?
Yeah, so for the record, Rick Hildebrand, Commissioner.
Oh,
This concept of test to treat, I think is one we've thought about a lot. And frankly, one that I had to do a bit of investigation on because I'm new to this. And I can say clinically, I oftentimes will see people who get delayed treatment. Timely treatment for these conditions is super important. With flu, as an example, if you don't get started on Tamiflu in the first 72 hours, you can't get Tamiflu. It's then no longer indicated. And anyone who's taken Tamiflu knows it works really well and you get back to work faster. And a lot of times, unfortunately, what happens is people may get a test, they may do a home test, which we have available now, but they can't get in to get prescription for treatment. Frankly, access to medications can sometimes be a challenge, but getting an access to a primary care appointment is a real barrier. Same thing's true for COVID. As we know, we want to get people treated as rapidly as we can. We do have oral treatments available that can be very effective in reducing the disease burden and the infectivity of people. And strep throat, another common infectious disease. It's really can be very dangerous if you delay treatment with strep throat. Heart valve problems. So, this is intended to improve access in the way that we looked at improving access to testing in the past with COVID era changes, and does empower the pharmacists to prescribe. The other thing to say is, as our colleagues at OPR said, we're going to be working together on having a very tight protocol here so that it's very clearly defined, what are the inclusion and the exclusion criteria. Other states have done this, they've done it very successfully. Usually includes provisions like if you do test positive and get a treatment, you have to have a follow-up appointment with your primary care physician, which I think is prudent in many of these cases to ensure that you don't have any ill effects of the treatment. So there's a lot of protections that we'll put in place with this. But I think this is an opportunity to improve access to Vermonters for common conditions that can at times bog down urgent cares in other places and opens up another venue for care.
I'm sitting here flipping through the RHT grant, and I don't know if you have this or maybe Jill Olson. So this was part of the Rural Health Transformation Grant. And we were awarded this, and it was approved.
Yeah, so this is one of the approved things in our budget.
How much is being allocated to that? Does anyone know?
I don't. It's primarily going to be led by DVA.
Okay.
And when we discussed this, it was clear that I was going to work with DVA to operationalize this to make sure it went well. But DVA is the main agency working on it. But
Okay.
Jill is.
Oh, I found it.
You found it. Okay,
$1,070,000.
that sounds right.
Okay, so if we do not do this, we actually wouldn't even be able to spend that money.
Yeah. If we never did this, that's true. If we said we don't feel the timing and we want to, wait a year, we would struggle to spend $1 million this year on that program, which has implications in the RHTP program. But it would be a challenge. So that is a consideration. It's not the only consideration here. I mean, I think we should take this, in the context of, hey, this is a thing that many other states have done. They've done it effectively. It's been successful in improving access for these conditions, and we're going to have important guardrails.
Great. Thank you. Oh, go ahead, Leslie. I'm sorry.
Thank you. This will take effect on passage. So what do you imagine the turnaround time might be on getting your protocols ready
Yeah.
to do that?
Well, and part of that, I believe the reason we're pushing for on passage has to do with the timing of this RHTP. So we want to get up and running rapidly. Okay, we still need to get RFPs out the door. We've got things that we have in front of us to do this. I don't want to get ahead of our OPR physician colleagues on this. Okay, the good news is there are protocols that do exist in other states that we can shamelessly copy from in many ways. Okay. But you're right, there's a tight time frame on that. We're well aware of that.
Yeah, I think so. Some of us who had the opportunity to listen to the primary care, and you're talking about getting follow-up in your primary care, like within a week, like forget it. Or, that. So I'm glad to be able to know that we can offer other venues for people to get care.
Yeah.
But what if we can't get care? I mean, if you write into your protocols that they're going to get follow-up in a week and that's not doable, then what?
Yeah, again, there's a lot of other pieces we're going to have to figure out with this. I don't have the answer to those, but work with VMS and our providers to make sure we do. I speaking as a provider, I can tell you, yes, you're right. When you ask for an appointment, they may get, but when you have a urgent medical need, there's ways that can get addressed as well. And every clinic has a different way of doing that, but it oftentimes goes to asking the doctor, say, hey, I have this need, can it be done on a sooner basis? And they stay late, which is really unfortunate. I know we all hate to have our
Then you burn
primary care.
out and that's
You're,
that.
you're right, but that is what happens in many, many, many clinics where when there's an urgent medical need that, people, they work through their lunch hour or they, some people thankfully do have open slots that they keep
Built into their schedule, yeah.
specifically for this, and that's a prudent practice.
Do you think there are other people that could be the follow-up, process rather than, I'm wondering.
Yeah, urgent care would be the other place to look, which again, the point is not to burden our urgent care, but I don't know the answer to that, but I think it's certainly worth looking at. What's the right way to follow up after having,
I would say a lot of people don't have access to urgent care.
I know, yeah, that's our true.
And my concern is people will go to the emergency department for
That
it.
is what we want to
Absolutely,
avoid, right? And that's part of what we're trying to prevent here. Is that,
They have to be seen, or, some
Yeah.
of those drugs, it's horrible. It could be horrible stuff. So
Yeah,
for some people,
right.
so, needing follow-up and having
Mhm.
that access.
Yeah, and again, access to, this doesn't solve our access to primary care. You guys know that. I mean, we
We're
have
just
so
adding
problems.
it. You're adding more
It just-
demand.
Well, the demand is there. This is trying to at least have a venue for early treatment. So you can get timely treatment. It doesn't obviate the need for primary care, follow-up in many cases. But a number of people are going to be negative that would be using up primary care visits. So that could be
So do you think that everyone that takes the drug needs follow-up, or maybe could that be perhaps rather than absolute?
again, I
Yeah, I
wanna
know
look-
you're gonna work through
I
your
got-
thing,
I got-
but I'm
I
just
gotta look
wondering
at
about that.
Yeah, that's a fair question.
Oh. This, not really in the scope of it. I do realize what we're doing here, but and maybe Jill would be better to answer just from the Diva side rather than the health department. Are these reimbursable services? So like if you're,
I believe.
how is that reimbursed?
So I actually would want to go back to Diva to talk to them about that, but that'd be the only way to make this sustainable, right? It would need to be a reimbursable service. I think this is why we've got interest in, from pharmacies in doing this, but Jim, I think, so, but I can get you those details.
My understanding is that the intent here is not to be using these funds though for the service itself, but rather to set up the pharmacy so that they
Yes.
can do it, which could be
And do training.
equipment and training and all those things. Because we specifically can't use RHDP money for
Yes.
reimbursable service.
Right, and to be, for this to be sustainable, we would want to have a reimbursement mechanism. So we can bring that up to you.
But it would be safe to say that this helps support our pharmacies
Patients,
and patients.
more to the point.
If it doesn't support our pharmacies, they're not going to take us up on the offer.
Yes, right.
So it is in our best interest to make this, structure this so that it supports our pharmacies.
Right. Okay, well, great.
Right.
Any other questions for Dr. Elba? Thank you. All right.
Thank you, SG.
Stephanie, want to come on up?
Hi, Stephanie Winters. I am the Deputy Director of the Vermont Medical Society. Thank you for inviting me. I threw together some testimony, so hopefully it makes sense. I want to begin by saying explicitly that pharmacists are essential members of the healthcare team, and that broad, unrestricted test to treat authority moves beyond, I think, what we would want to see in our state. It fragments patient care and introduces new safety risks. But I will say Vermont's state protocol-based model works. And it's the model that Vermont should continue to follow. And VMS supports that the amendment language regarding COVID, flu, and strep testing, test to treat, is condition or medication specific and protocol driven and not open-ended. And as you all were talking, I just would be remiss in saying that if we had a really well-supported and strong functioning primary care system, we wouldn't have to create all these alternative systems like urgent care or like, moving care into pharmacies, which are already so busy on their own. Period. I'll just say, let's remember, and I know this committee knows that and wants to support primary care, but just a stop point. And more on the protocol-based approach. Some of you weren't here when we passed that in 2020, but we have a strong history of working together to create this protocol a landmark example where that expanded pharmacist prescribing authority safely and deliberately. So through jointly approved protocols by OPR and by the Commissioner of Health. This has been a really transparent process. We've been part of the Board of Pharmacy meetings, had input, and really created some really strong protocol that I think creates that patient safety and is the most effective framework for expanding pharmacy practice. So we have appreciated that protocol process.
Can I interrupt you?
Yeah.
really quickly? As part of that protocol, the existing protocol, is there mechanisms around continuity of care?
Yes.
To ensure that.
Yeah. So I think all of the protocols require asking about a primary care practitioner, making sure people have them. If they don't, trying to do the connection. And then they all are different, right? Depending on the medication. So oral contraceptives are different than NRT, are different than immunizations. And so nicotine replacement therapy. So, they will all be different. And as you were talking to the commissioner about like, what will this protocol look like? I think that remains to be seen. We've talked with some of our pediatric colleagues about strep and when a patient should be referred. And, obviously there are concerns about finding primary care. My hope would be if there is a good communication and collaboration between that pharmacy and primary care in that area, that they're, have a sort of peer-to-peer contact and get the patient in. I would assume that the protocol might say a referral to primary care within a certain amount of time, not necessarily that you get in, but we don't know what that protocol will look like. Just a little a side note.
I just wanted to ensure that
Yeah.
pharmacies would be sending documentation to a primary care that, hey, your patient was seen, they were prescribed, that.
Yeah, I mean, that would be,
And in the existing protocols?
yes, and I think it's using some of it's the VPMS, some of it's the immunization registry, and then yes, there is a 7 days or 5 days. I'm looking at Carrie with OPR.
Yeah, Executive Officer Board of Pharmacy. All of the protocols have the same format and they do involve informing the primary care provider of what had happened through a variety of different.
Yes.
Great, thanks. Sorry, keep going.
No. Just a couple of implementation considerations that we just want to point out that there is some worry about allowing pharmacists employed for a for-profit entity to both diagnose and prescribe. It could, introduce a potential conflict of interest. And also just worrying about our pharmacy colleagues. And if you've been in a pharmacy lately, you know how busy they are. So just their workload is busy too. And as we talked about, they may not want to take it on, and they don't have to take it on, but some of these are employed and they may kind of have to take it on. So just considerations there. In conclusion, we support safe collaborative models of pharmacist engagement, those that complement and not replace patient-centered medical homes. We support that this language is condition or medication specific and protocol driven, not open-ended. And we very much look forward to taking part in the protocol process, which we hope will address information sharing, coordination with practitioners and other primary care practitioners, notification after prescribing, patient screening and referrals, and then training, oversight, and obviously protections for both patients and pharmacists from being placed in unsafe clinical situations and decision-making.
Any questions for Stephanie? Go ahead, Leslie.
Can you talk about what you mean by oversight? In your next to last bullet, including training, oversight, and data report. What does oversight mean?
I mean, I think oversight by OPR, their licensing facility, making sure that the protocol is being followed and how that all works with the collaboration and coordination.
Is that already in play in that OPR or is it?
Well, yes. Yeah, the licensing body already looks over them, just we're implementing a new process, right? They don't currently do testing and treating, so there needs to be processes for how to monitor that.
Yeah, that's what I'm wondering about. Thank you.
Any other questions? All right, so, two things. So I have sponsored this amendment. And then there's a couple other people on it. If anyone else would like to, put their name on this amendment, it'll be a floor amendment.
You're inviting us to?
I'm inviting anyone who would like to sign on. We
I
can
would.
still do that. Okay, so yeah. Let's council. So we have Wendy Critchlow.
I'll add my name. If we can also put in a clause about universal health care.
Or to leave Brian off.
No, just add my name.
Brian and Wendy.
This one's Karen.
Oh, Karen, the other Wendy.
The other Wendy, oh.
The other thing is I have spoken with the chair of GovOps, and I'm actually going in there tomorrow afternoon to present this. And, you know, the chair of GovOps knows all about it as well, so this is not a big shocker on the floors or anything like that.
I saw you're on their schedule too to present it.
And I believe that the same witnesses that we've just heard from will also be there. So they'll be in that committee tomorrow.
So this came from OPR to here.
I think it's
in
the
a little.
OPR miscellaneous, the housekeeping bill or something.
OPR, the annual OPR.
So you just noticed that this wasn't here and you were hoping to add it.
No, that's not how it came about.
Curious about how, where's the origin stories, I love them.
Yeah, we've been coordinating with BDH and the Rural Health Transformation Program. And that conversation kind of culminated in last week. And so those grant funds, I believe, were recently awarded, but I can't really speak to the rural.
Looking at you.
I can chime in.
Yeah.
Yes, I mean, it was pretty clear, like, as with, if we don't do this, we're gonna struggle to get this program.
Delay it and.
Yeah.
So someone recognized this gap and.
Yeah.
Yeah, got
That
it.
was really yes.
Call at the Frida Kahlo Blue House last week on this.
What? We what?
Nothing. Okay, so, I should take a straw poll on, if the committee supports the amendment. I think I just need to do a straw poll. So all in favor of the healthcare oversight on this amendment, I would, with a show of raise of a hand if you support the amendment.
Is it, okay. Amendment of H 588.
Yes, okay, 10-01. Thank you. That'll be my lead-in. And
Wayne.
okay, all right, so we have a little bit of time left. Do we want to pivot back to, thank you, everybody, for coming in. We want to pivot back to H 814 and see the changes that Jen has made in record times.
Epic changes.
Yeah. Okay. Yes.
I honestly did not even know that was possible. I honestly do that. Love this stuff. I love your amendment.
It's yours now. So
Ours.
we're still online, just.
Okay.
Sorry. Actually, this is.
Again, that face.
Okay. I don't have to put it in today, do I? It's necessary to appropriations. Okay,
And in fact, if appropriations and ones that you.
yeah, that's what I was thinking is maybe I'll wait to submit it until it's gone through its other places in case anything changes. So. And if so, then I will advise everybody on any changes that are made to it. All right, thanks, Jen.
Again, Jen Carvey, Office of Legislative Counsel. We're going back to page 814. So I cleaned it up and it's actually a clean version because the changes were pretty minimal, but I will walk you through what they are. Oh, and I have not sent it to,
Send it to
I
Tasha.
have not sent it to Tasha, so she has not posted it.
Just drop one.
No, I don't have it yet.
You don't have it. It's gonna be 2.1, but
Yes, it'll be 2.1 and it's winging its way over to Tasha.
and I only said that because I saw it really quickly when you put it up on the screen. Not because I still don't know. Is it one?
Yeah, it depends. I just made your amendment 1.3. Okay.
Excuse me.
Windows open.
All right, do you want me to wait until it's posted or do you want to, okay, no, just good. All right.
His fault that he walked out.
So this is draft 2.1 of H 814, an act relating to neurological rights and the use of artificial intelligence technology in health and human services. So no changes to the intent section. In the neurological rights, just I incorporated the change from the last draft and it's clean now. So that was number 3 changed in the previous draft and now it's incorporated. So now we jump all the way to section 3. We don't have to go through the 23 pages of strikers. And we get to the Artificial Intelligence Advisory Council. So we did a couple of things here and I just want to make sure I'm highlighting them all for you. So the first thing I did was simply to swap out, instead of having Secretary of Human Services or designee being looking like a totally new ad, it's now just striking the Commissioner of Health and inserting instead the Secretary of Human Services and keeping the or designee. And then separately adding as a new J, the member with experience in public education. I think that was the one that was, had looked like it was replacing the Commissioner of Health. So that's a standalone J. And then down here we have L, M, got an and N is one member with relevant knowledge and expertise appointed by the governor. And then in the, and section 4, we have the council in coordination with the director of the Division of Artificial Intelligence and in consultation with interested stakeholders shall, and then we didn't make any change to what they're actually doing. And just incorporated the prior changes, got rid of the highlighting. And then finally, the effective date, the act would take effect on passage.
Brian, did you see the one member with relevant knowledge and expertise appointed by the governor is now N?
No.
And she cleaned up so that it was.
You scroll up slightly. Sorry, I had to run out for a second. Look slightly more.
So it's a little bit.
So I made it,
now.
Commissioner of Health becomes Secretary of Human Services here, and then what was
Oh, I see.
public education one stands by itself as J, and then the new governor
Yeah.
is N.
I see what you did. Thank
Easier
you.
to explain. Yes, should have done it
Less
that way.
confusing people.
And then we got the consultation with the stakeholders and effective on this.
Great. Any questions?
How many pages are there now? From 27 to 6.
Go ahead, Cal.
So we, and I'm sorry if I missed it. So we will not be looking at, like, for example, Vermont Medical Society has given us 5 recommendations of clarity. We won't be looking at any of the emails. We're just,
I think that they submitted a lot of things, clarity, which have now completely been struck. Because it went from 27 pages to Would the Vermont Medical Society like to comment?
Sure. Stephanie Winters, Deputy Director of the Vermont Medical Society. Yes, when I testified, this language was not official language and had just come out that day, and I prepared my language on the original, the OG bill. So, this is completely different. So those comments.
So that means you're 100% comfortable with the new.
With the commission, yeah.
Go ahead, Brian.
You're gonna be given a seat on the council now. Do you feel like that having a seat on the council will give you the opportunity to address these things as those policies are considered? Like, you know, as you look at how any
I would
regulation.
hope that would be the case.
Okay.
Depends on how the council is run, but I would hope that that would be the case, and then we can build what you're looking for and address those.
Okay. Can I ask one more question?
Yeah.
In preparing the original bill, I did review, the American Medical Association has extensive guidelines on artificial intelligence. And that's why I mentioned them. And so I just wanted to ask if there's anything more you would say about what you have to offer based on those guidelines. Do you feel like?
I can't speak to that right now. I do know that they're calling it, I think, augmented intelligence. I don't know.
Okay.
Yeah.
That language is different.
Yeah, and we have some of that language.
Okay.
Yeah.
They do.
If you're comfortable with where we've landed.
Yeah,
Okay.
I mean,
All right.
yes, it's very simple.
Okay.
You know, it depends on your policy decisions. I sound like Jen now.
Yeah.
It's up to you on your policy decisions. There's nothing harmful in
Yeah.
creating a commission to really discuss augmented or artificial intelligence and its effect on healthcare.
Leslie.
Just curious, Renee, what's the process for the medical society to appoint someone? How do does that? Is it a board decision? Is it a ED decision?
We probably would bring it to our board. What we would probably do is send it out in our weekly newsletter and see if there's anyone that's interested. Also would reach out to people we know have expertise in AI or technology in healthcare, which there are a number of them. And so we would work both ways to identify an appointee.
All right, any other questions? Go ahead.
Did the Office of a Healthcare Advocate express any interest in this at all?
They supported it, but said they don't feel like they need a seat on it. That they will weigh in if needed, but they came in and they supported it. It was quick.
Yeah, the Office of the Healthcare Advocate just had to walk out.
Standing right there.
Yeah, if he had something.
Yeah, because I was like, wait, they would be in. I'm not recommending this. I'm just thinking it would have made a lot of sense to have them be the one to recommend someone with ethics and human rights.
Well, if everyone has had their questions answered and feels prepared, I would entertain motion be approve, and this will need to go to appropriations. And I'll consult with the chair of GovOps, maybe when I'm in there tomorrow on the other thing. About maybe just doing a drive-by of this, or I'll speak with him and find out which he'd like to do.
Just
Go
a
ahead.
question.
Yeah, of course.
I know we've been told we do policy, we don't do appropriations, but do you have any idea what this will cost?
Did hear that.
I think they did. Don't they get like would they get a daily?
It's $50
Doesn't matter.
It's $50 a meeting per person for
Right,
those.
it depends how many.
Yes.
But we didn't hear like an estimate of like, when they were here, we asked this and they said the additional expense would be like several $100s
I
more.
just hate sending something over there when they say, oh, those guys don't even know what this is gonna cost.
Yeah, we did make
Okay.
that money on that.
It was it was like gonna add several $100s to the budget. Something like that, like. I don't have a fiscal note, but I remember when we looked at it with them. Huh?
De minimis,
What does that mean?
very little,
Wow.
petite.
Unmeasurable.
And you know what? They could choose to strip the stipends out of it completely if they want. They've done that in the past, if they
Yeah.
think something, so they have the power to do that and that's their decision.
Okay, So I would entertain a motion that we pass version 2.1 of H814. Anybody willing to make a motion?
I make a motion that we vote on. H.4.
Is our clerk ready? All right, and the clerk can call the roll.
Brian Changer,
Yes.
Wendy Critchlow,
Yes.
Alan Demar,
Yes.
Leslie Goldberg,
Yes.
Lori Houghton, Karen Leaders,
Yes.
Deborah Powers first, right? Yes, Valerie Taylor. And just Daisy Rebecca.
Yes.
Francis McCall,
Yes.
Chair Buck. Yes. And once again, I've forgotten to find a reporter of the bill, but I'm gonna go with Representative Chena. You will be.
Are you sure Penny doesn't want to do
You
this one?
will be reporting this bill.
I voted for it.
Yeah, the most you're gonna get, Brian.
Yeah,
All right, so Representative Chena will be reporting.
I'm just a study committee.
Thank you, everybody.
This is.
This is.
Favorable
Is it a
with-
strike call?
Favorable with amendment. Yeah, and draft 2.1.
All right, well, thank you. We can go off of that.